Now, we've known that you can give SSRIs to people and it helps the depression. And if you need tryptophan to make 5-hydroxytryptamine, and so you can artificially deplete that very quickly by just having the person eat or drink nothing but water and a liquid protein shake that is depleted with tryptophan so they can't make serotonin. And you can actually counteract the effects of an antidepressant. Let's say somebody is stable on an antidepressant, and you put them on this tryptophan depleting protein shake, and within 24 hours they'll get depressed. Well, lo and behold, you discovered that the same thing happens in panic attacks. And that tryptophan depletion has no effect on controls exposed to carbon dioxide. But if you did that in patients with panic disorder, they had stronger panic attacks, higher levels of subjective anxiety, and more physical symptoms of panic. In other words, they were worse. And if you use the immediate precursor to serotonin, L5-hydroxytryptophan in double-blind fashion, you basically decrease the anxiety panic symptom score. So you can make it worse by depleting it, and you can make it better in panic sufferers by using the precursor 5-hydroxytryptophan. So there are some genes that are associated with it, and they appear to be stronger when early onset panic disorder cases and those with prominent respiratory controls were there. Now, what's interesting, we're going to talk about the anxiety response to fearful or angry faces in social anxiety, and it turned out that one of the alleles was also sensitive to fearful and angry faces. And so we think that this has to do with those those acid-sensing ion channels. Now, there's another way that you can treat panic, and that is using biofeedback using capnography. And there is a device on the market called the Free Spira that is available for rent, and you can actually train the person to change their breathing. And they did 3 studies to get FDA clearance for this device. And basically, they were getting about 80% of people panic-free at 12 months. There was a lot of adherence, and they had some pretty significant outcomes. They used the Panic Disorder Severity Scale, which is available. Here's a reference to it. And what they would do is you would have, and this is a patient of mine who has had panic for probably 20 years, has been treated with alprazolam, currently at 4 milligrams a day, and really wants to decrease or come off that. And this was her one of her first session where she was trained to look at her carbon dioxide that's exhaled through this nasal cannula in her nose. And it's looking at the carbon dioxide, and the goal is to increase the amount that's exhaled. In other words, decrease the amount in your brain, and to slow the breathing and to make it very regular. So this what you see is the top lines here are the carbon dioxide, and you want to have them in these in this range here in the dark blue, and you want to have your respiratory rate in this green shading. And what you see, these blocky looking things have to do with variability of it, and you can see that she was changing a lot there, and she was being trained to breathe 13 times a minute. And this was on September 5th, and by the end of it, She was doing much better in keeping her carbon dioxide more stable in a steady range, and you can see how regular her breathing is at this point. There's a patient portal that goes to the company, that goes to the patient, and comes to me, or the clinician. And here were her outcomes. And if you looked at her first sessions, her panic disorder severity scale was basically not too good. She had a score of 15 with 11 symptoms, and you can see what they were over there. And by the time she got down to the from September 5th to September 26th, her score had gotten down to 8, and she only had 3 symptoms. And she has some mild agoraphobia, and either with or without agoraphobia, an 8 is considered slightly ill. So she's gone from markedly ill to slightly ill. And here is a nice graph of it. The number of symptoms went from 11 symptoms down to 3. Her panic disorder scale went from 15 up here, and it went down to 8 down here. So there was definite improvement with her. So there are other medications that you can use. The antidepressants, ibipramine was the first. SSRIs, SNRIs, and MAO inhibitors can help. MAO inhibitors are, because of their danger, are rarely used for panic. Clonazepam and alprazolam are approved for panic disorder. They're a controlled substance and potentially addictive, and so people don't typically like to start out on that. Gabapentin has some anecdotal information. I've certainly used it. There are no controlled trials, and unfortunately it's abused, and currently it is a scheduled drug in Tennessee now. So what are the FDA approved medications? The Zoloft or Sertraline, Paxil or Paroxetine, Paxil CR or Paroxetine ER, Prozac, and Effexor or venlafaxine. All of them except Prozac are also approved for social anxiety disorder, and you can see there's a difference in the starting and total dose for social anxiety versus panic disorder on these. And Zoloft and Paxil are approved for panic disorder maintenance, and these are all once daily dosing. Now I will say to you that the package insert has sometimes been described as the most misleading medical information there is when it comes to clinical use. The package insert is compromised wording between the Food and Drug Administration and the pharmaceutical company about how they can market that medication. So, you know, sometimes if you're a prescriber, you get a little call or fax from a pharmacist saying, you know, you're really going way too high, or you shouldn't be doing this, blah, blah, blah. And you know, a prescriber, you're allowed to prescribe off-label, and you know, in psychiatry, probably 50 to 60% is off-label. And then the other time is sometimes people don't really know what's in the prescribing. So one of the very interesting aspects, you know, if you tell somebody I'm taking 5 to 6 milligrams of Xanax a day for panic disorder, their friends might say, what kind of quack are you seeing that's giving you that much? But guess what? If you look up on the FDA's website, you can find the package insert for Xanax, and they showed that the average dose was 5 to 6 milligrams a day of Xanax. And so guess what? You can use that much. Gets a little more problematic then, but that's just, you need to know what that is. On the Xanax XR, which was meant to be a once a day Xanax, but really turned out to be really kind of required it twice a day, 4.2 to 4.6 milligrams was useful. In the Klonopin package insert for panic disorder, the mean dose was 2.3 milligrams a day. Klonopin is an easier drug to use because of a longer half-life, and generally twice-a-day doses work quite well. So let's look at Sertraline, which has the approved indication. And the mean number of panic attacks in the randomized study was, about 5.5 to 6 panic attacks. And you can see that it separates from placebo by week 2, and significantly from there. And the number of panic attacks, if the average was 6, well, you can see by week 9 that many of the patients in this study were panic-free. Compared to placebo, that they were averaging about 3 panic attacks. They recommend starting at 25 milligrams a day for a week, and then a flexible flexible titration to 50 to 200 milligrams a day. They looked at, here was another study that Bandolo did and published in Journal of Clinical Psychiatry, looking at how does Zoloft and Paxil, or Sertraline and Paroxetine, compare. And what they found was there were no significant differences from in the first 12 weeks, and then they tapered off of them at week 15, and there was it looked a little better with Zoloft and Paroxetine. But by week 12, there wasn't a big difference. There was a difference in the two by week 15 after they had tapered. And as far as panic disorder free, more people on sertraline were panic free than the paroxetine. Now, one of the significant issues is, as you know, if you have prescribed paroxetine, there's this little issue with weight gain. And the percent of patients who gained more than 7% of their body weight was much greater with 7% of the Paxil patients versus 1% of the Zoloft patients. And actually, there was the panic-free patients increased by 4% with sertraline, but decreased 11% with paroxetine. So I may have misspoke there. It was actually paroxetine had a better outcome as far as panic-free, but more weight gain. When you look at, here was an very interesting Brazilian study that has actually 9 years worth of follow-up, and this was first published in 2011. And they looked at an 8-week randomized trial with clonazepam and paroxetine. They had 120 patients with or without agoraphobia, had an 8-week study. And you could see that both paroxetine and clonazepam did very well in the mean number of panic attacks, actually starting pretty quickly. It was statistically significant by week 3. Now, there was some change as far as the difference compared to paroxetine, with clonazepam being a little superior and statistically better on weeks 3 and 4 compared with a mean number of panic attacks. Not a huge amount. You see the difference between 4.6 panic attacks versus 5.2 panic attacks, with a decrease, but it was still statistically significant. Now, let's look at the adverse events, and here we go. So if you look at clonazepam, there was overall, you have 57% were more drowsy. Paroxetine, it was 81% were drowsy. Sexual dysfunction, 11% with clonazepam, which is unusual. I guess maybe you don't want to have sex when you're having panic. But look at the sexual dysfunction, typically, the delayed or inhibited orgasm with paroxetine, 70%. There were some memory problems with clonazepam at 24%. Overall, it was even worse with paroxetine, 40%. Not much weight change with clonazepam, in fact, basically none, versus 54% of people on paroxetine. So watch out for that. Now, they actually followed up these people for 6 years. They discontinued the medications after 3 years. That was the design of it. They found 85% of the patients were still able to be followed. And they stopped it at 3 years, and they followed them up at 1, 2, 3, 5, and 6 years. I'm not sure what happened in year 4. It wasn't the Olympics. And if you had to resume medications or psychotherapy, or you had CGI scores greater than 1, or had panic attacks the month preceding it, you were considered a relapse. And this is when this was taken. Interesting, the clonazepam, which is typically used twice a day, in the study was only used once a day in the evening. There was no CBT. The psychiatrists did not use those techniques, nor did they encourage patients to go out and desensitize. And here's Kaplan-Meier survival curves. And you can see what happens is that you certainly did better with clonazepam at baseline. It got close to evening out by the 6th year. You'll see this issue with, what happened, why is this line so flat here? Well, remember, they were not assessed during this 4th year, so that's why it looks flat. So the 1-year relapse rates were lower with clonazepam, and remember, this is 3 years after coming off the medication, and they didn't find any other predictors such as agoraphobia, female sex, that predicted this. So that was a very interesting one. Now, what about psychotherapy for panic with or without agoraphobia? Martin Seligman, who pioneered positive psychotherapy in psychology and was a past president of the American Psychological Association, said that basically panic disorder is one of the most treatable of all psychiatric disorders. Agoraphobia does not typically respond to meds alone. Panic disorder has a significant relapse rate, which is reduced by psychotherapy. And as I said before in my opening, even if you don't provide psychotherapy, you need to know what is effective psychotherapy and know who are good therapists in your area. So when I explain panic disorder to patients, I will talk about client suffocation, reflex theory, and that sometimes people say, well, my panic attacks come out of the blue, and I can't, figure out what causes it, and they actually have a more favorable prognosis. They're less likely to cause agoraphobia. Treatment begins with understanding the basic concepts. It's your genes, environment, like just about everything else in psychiatry. That your abnormal breathing patterns are important, and that you tend to have an overgeneralizing catastrophic way of thinking. Now, one of the worst things that happens in panic is this, kind of hypochondriacal body scanning that happens, not the good mindfulness meditation body scan, but that panic-stricken, I felt my heartbeat. I was a little bit dizzy. I'm feeling, I think I'm blushing. I'm sweating a little bit. And this really is a huge contributor to the agoraphobic avoidance, because the person gets into this, if I can just figure this out, I can stop it from happening. And they really want to control panic. And where you start out is say, we're not interested in controlling it. We want to cope with it. So looking at, how your mother treated you and why you weren't picked for soccer games when you're in the 3rd grade is really not very helpful. Psychodynamic uncovering approach just doesn't really work very well, and I'll show you that. You really want to begin with now and do CBT. Breathing retraining is absolutely essential, and CBT is the gold standard. And one of the huge breakthroughs was psychologist David Barlow's concept of interoceptive desensitization. So, and that's looking at your internal sensations. It's important to define some terms: stress, worry, and anxiety, and how different they are. And it's important. One of the interesting things is sometimes people say, I'm really anxious, doc. I'm a very anxious person. They're sitting there fidgeting and moving their leg up and down and kind of moving around in their chair, and you can see them vibrating, and you say, well, what are you worried about? I don't worry about anything. You don't have anxiety, you have ADHD, and you're fidgeting. So you can have stress without worry. People that have a lot of aplomb, ER physicians, they have a lot of stress going on, but they're not worried. They handle it. Firemen, policemen, soldiers. Patients like to focus on triggers. What's causing this, and this dread leads to this terrible agoraphobia. In 1947, psychologist O. Hobart Moore said there were 2-step process of phobias, like in Pavlovian classical conditioning. If you have a panic attack in one setting or a situation, then that can condition you to be afraid of it. And then the second step is you avoid it, so you never get better. And this may explain why some studies show poor outcomes when therapy is combined with meds, because it actually decreases that. So they often happen out of the blue. When your brain says you're in danger, you think there must be some danger, and there's got to be something going on. How can I prevent this? If I can remember how it felt, I can make sure that it doesn't happen again. One of the aspects of this that my friend Jerry Fried talked about is that this fearful increase in body awareness actually leads to this fear-based body scanning. And what we want to do is help you stop